Welcome to the deep dive. Today we're really getting into it with a specific set of sources all about spirometry.
That's right. We're looking at how this, key lung function test is learned and used day to day in general practice.
Yeah, and we've got some interesting stuff here. Portfolio from a GP practice, Quisarts and Praktik Fonderson, detailing their experience learning spirometry through a course called CASPIR.
And there's also a case presentation, a transcript from a training video, even the course slides themselves. Quite a mix.
So our mission really is to pull out the most important insights from all this. How is spirometry actually learned? How's it done well?
And interpreted. What does it all mean for actually helping patients in primary care?
Exactly. Let's jump in and unpack this journey.
Okay.
So it starts with this practice. He's Arts and Praktik Fonderson. We hear about Dr. Sabine Fonderson, the GP, and Jessica Van Rosbergen, the practice assistant.
Right. And they took this case per course together, and the sources are pretty clear about why they felt they needed it.
Yeah, Dr. Fonderson mentioned having sort of limited spirometry training back in medical school.
Exactly. And maybe even less time for it during the COVID period, she mentioned. Plus, when you're setting up a practice, that takes priority initially.
Makes sense. But then you look at their practice size, like 30, 50 patients.
And 207 with asthma. That's a significant number.
So the goal became for the GP, for Dr. Fonderson, to actually assess the results herself, not just rely on others.
Yeah, they wanted that confidence, that in-house capability.
And it seems the course helped. They specifically mentioned finding things like the ROER-model and the Z-score useful, practical.
Which tells us straight away, okay, those are core concepts we need to understand from these materials, ROER and Z-score.
Definitely. But before we interpret, we need the basics. What does the test actually show us? The sources talk about two main graphs.
Right, the flow volume curve and the volume time curve. Those are the visual outputs.
Okay, so the flow volume curve, let's picture that. It plots flow, right? How fast the air is moving.
Yep. In liters per second, usually up the side, the y-axis, against volume, how much air along the bottom.
Liters. And exhalation goes up, inhalation down.
Exactly. You get that peak as you blow out hard, then the curve drops off. Inhalation is the loop underneath.
Got it. And the volume time curve. Sounds simpler.
It is, pretty much. Just shows the total volume blown out over time in seconds. Starts at 0, shoots up fast, and then hopefully flattens out at the end.
That plateau is showing you've emptied everything out. Okay, so from these curves, we get the key numbers. FEC.
Forced vital capacity. That's the total amount of air you manage to force out after your deepest possible breath in. Your total capacity, essentially.
And FEV₁. Everyone talks about FEV₁.
Forced expiratory volume in 1 second. Super important. It's how much of that total volume you blast out in just the first second.
Right. And the ratio, FEV₁ divided by FEC. That tells you the percentage you got out quickly.
Precisely.
Yeah.
What proportion of your total came out in that first crucial second?
And PEF. Peak expiratory flow.
That's just the fastest speed the air reached during the whole blow, the highest point on that flow volume curve.
Okay, numbers and curves. Now, you mentioned the Z-score earlier. The sources highlight using this, especially for the FEV₁, FEC ratio, instead of older rules like the 70% cutoff.
Yes, and that's a really significant shift emphasized in the material.
Why is the Z-score considered better, particularly for a GP setting?
Well, because it's personalized. It compares the patient's result not to a single fixed number, but to what's expected for someone of their specific age, height, sex, and even ethnicity.
Ah, so it counts for natural variation.
Exactly. A Z-score below Nackisher's 1.64 usually flags a result as being in the lowest 5% compared to similar healthy people. It's just a much more accurate way to see if a value is genuinely low for that specific person.
Right. It helps avoid mislabeling someone, older who might naturally have a slightly lower ratio anyway.
Precisely. It adds that layer of context.
Okay, so we know what we're measuring. But getting good measurements, the sources really hammer home how much technique matters. That seems like a huge practical challenge.
Oh, absolutely. It's critical. The work protocol they included lays out the steps, patient sitting up straight, loose clothes.
Dentures out if they might interfere.
Right, and ideally no smoking or big meals just before. Then you need the nose clip, the mouthpiece.
And the actual maneuver. It sounds simple, big breath in, blast out hard and fast, but it's tricky.
Very. It's a maximal deep breath in, immediately followed by a forceful, fast, continuous exhale. For adults, they stress at least 6 seconds.
6 seconds of continuous blowing.
And then a full breath back in at the end.
And the training materials, they talk about what makes a blow technically acceptable. What are those key things?
Yeah, this is crucial. You need a really sharp, fast start. No hesitation. The curve itself needs to be smooth.
No coughs partway through.
No coughs, no glottis closure, no interruptions. And critically important, they need to blow out completely. You see that on the volume time curve as a clear plateau for at least 1 second.
Meaning they really emptied their lungs.
They gave it everything.
And you can't just do it once, right?
Yep.
There's repeatability.
Correct. You need at least 3 of those technically acceptable blows. And then the 2 best FEV1 values need to be close within 150 milliliters of each other.
Same for the FVC, within 150 milliliters.
Exactly. That shows the patient is giving consistent maximal effort, not just one lucky good blow.
And this is where, the rubber meets the road.
Mm-hmm.
The sources mention case 2 and case 4.
Yeah, those cases explicitly noted issues like a poor start, not enough effort, or wiggly curves.
So the results were marked as having limited reliability.
Right. Which is a key takeaway. You might get numbers, but if the quality isn't there, you have to acknowledge that limitation when you interpret it. It really affects how much you can trust the result.
That puts a lot of pressure on the person coaching the patient, often the assistant.
It does. And then there's the equipment side, too. Calibration with that 3-liter syringe, cleaning, keeping logs. It's a whole system you need to manage.
Right, not just plugging in a machine. Okay, so that's the basic test. But the sources also talk about special tests, like the reversibility test.
Yes, that's mainly used during the diagnostic process.
How does that work according to these materials?
Okay, so you do the baseline spirometry, first get those initial numbers, then you give a bronchodilator.
Like salbutamol.
Exactly. The source specifies 4 puffs, 100 micrograms each, using a spacer, importantly, given 30 seconds apart.
Okay, and then you wait.
Wait 15 minutes, let the medication really open up the airways if it's going to. Then you repeat the whole spirometry test.
And what shows significant reversibility? What are you looking for in that second test?
The definition they use is an increase in FEV1 of at least 12% compared to the baseline, and also an absolute increase of at least 200 milliliters.
Both, 12% and 200 milliliter.
Both criteria, yes. That shows a significant response to the bronchodilator. It helps understand airway reactivity, but, the sources are careful to say it doesn't automatically equal asthma on its own. It's a piece of the puzzle.
Got it. And there's another concept mentioned, variability. That's different, right? Not within one test session.
Correct. Variability looks at changes between different spirometry tests done over time.
How much time?
Within a maximum of 1 year, but with at least 4 weeks between the tests being compared.
And you're looking for similar changes, that 12% and 200 milliliter difference in FEV1.
Exactly the same criteria, yeah. A change of 12% and 200 milliliters in FEV1 between tests done weeks or months apart.
Why is that useful?
Well, think about asthma. Symptoms can come and go, right? So someone might have perfectly normal spirometry when they're feeling fine.
Okay.
But if you test them again when they're symptomatic or just in different times, and you see that significant fluctuation, a drop and then recovery in FEV1 between tests, that's strong evidence for variable airflow limitation, it's characteristic of asthma.
So it's another way to catch that variability that might be missed in a single snapshot.
Precisely. Using the test dynamically over time.
Okay, so now we've got good quality data, potentially from baseline and reversibility tests.
Mm-hmm.
How do we interpret it? The practice uses this ROER model.
Yes, the sources show that's their systematic framework, ROER.
Let's break it down. First R, restriction. How do you spot that pattern?
Primarily, you're looking at the FVC, the total volume. If that's low, especially if the Z-score is less than negative 1.64 and you don't see signs of obstruction.
So a low total capacity, but the ratio's okay.
Kind of. But the source adds important caveats. A low FVC isn't always true lung restriction. Could be poor effort, remember.
Right, if they didn't blow out fully.
Or even severe air trapping, what's called hyperinflation, can sometimes lower the FVC reading. So confirming true restrictive disease usually needs more investigation, maybe referral. Case 5 was an example where they considered this pattern.
Okay. Next, O, obstruction. This must be common in primary care with asthma and COPD.
Very common. This is where that FEV1 FVC ratio is key. If it's low specifically, Z-score below minus 1.64, that indicates obstruction.
Air isn't getting out quickly enough.
Exactly. And on the flow volume curve, you often see that classic scooped shape during the exhale. The flow drops off much faster than normal after the peak. Case 6 was shown as a clear example of obstruction.
Then E, Ernst. Severity. How bad is the obstruction?
That's graded based on the FEV1, but expressed as a percentage of the predicted value for that person.
Compared to what's expected for them.
Right. The sources list the standard grades. Mild is 80% or more of predicted, moderate is 50–79%, severe 30–49%, and very severe is below 30%.
And that's usually based on the FEV1 after the bronchodilator for COPD, right?
Typically, yes. For grading COPD severity, you look at the post-bronchodilator FEV1% predicted.
And the final R, reversibility. Reversibility. Back to that test.
Yep, just systematically checking, did they meet that criteria we discussed? The 12% and 200 milliliter improvement in FEV1 after the salbutamol.
Okay, ROER. Restriction, obstruction, severity, reversibility. A clear pathway.
It provides that structure for interpretation.
Applying this stuff to the case studies in the sources is where it really comes alive, though. Like, case 1 young smoker has symptoms, but the spirometry is normal.
Yeah, that immediately tells you spirometry isn't everything. You can't ignore the clinical picture.
The symptoms, the risk factors, like smoking, they still matter hugely. A normal test doesn't just automatically rule everything out.
Absolutely not. Maybe the test caught them on a good day or something else is going on. It highlights the need for clinical judgment.
And those cases 2 and 4, again, with the poor technique,
Yeah.
there's such a good illustration of the practical challenges.
Definitely. It shows how easily data quality can be compromised, highlights the importance of good coaching by the assistant, and the GP needing to be aware of those reliability flags.
Case 5, where restriction was considered, just shows GPs are thinking broader than just obstruction.
Even if confirmation needs referral.
And case 6, older patient, COPD, but also a history of lung cancer treatment residue. That screams context matters.
It really does. You've got the spirometry showing obstruction, which fits COPD, but you have to interpret that alongside their age, their history, other health problems. It's never just the numbers in isolation.
That case also showed non-significant reversibility, which often fits more with COPD than asthma.
Right. Now, case 8 from the portfolio itself, that one's really fascinating. It brings out some real-world nuances.
What was the story there?
Patient with a history suggesting maybe a mix of asthma and COPD. They'd stopped smoking, spirometry was done.
Okay.
And the report concluded there was significant reversibility, noting a 17.9% increase in FEV1.
17.9%. That's over the 12% threshold. But wait, didn't we say it needs the 200 milliliter increase too?
Exactly. That's the interesting part. The source report called it significant, but explicitly noted the absolute increase was only 30 milliliters, not 200 milliliter.
Huh. So technically, by the definition they laid out, it wasn't significant reversibility. Why call it that?
Well, that's a great question the source material raises. It could be a few things. Maybe in practice, a very large percentage increase is sometimes given more weight, especially if the baseline FEV1 was very low, or maybe different software flags things differently.
Or just variation in interpretation?
Could be. But the key insight is that the report is data, a tool. The clinician still has to look at it, maybe notice that discrepancy, and integrate it into the whole picture. It shows interpretation isn't always black and white, even with rules.
And what happened with that patient in case 8?
Even more interesting, despite those findings which might point towards an asthma component needing treatment, the patient felt clinically well, stable without medication.
And they chose not to start the therapy that was suggested.
Correct. It's a fantastic example of shared decision-making. You have the objective test data, the potential diagnosis, but then you have the patient's actual current state and their preference. It all has to come together.
Wow. That's really putting the patient at the center.
And there was another case from the Module 6 presentation slides that reinforced this. It's stress spirometry is often a process maybe needing multiple tests.
Right.
And that interpretation absolutely needs clinical context. They mentioned using symptom scores like the CCQ, the clinical COPD questionnaire.
Makes sense. Quantify how the patient feels.
Exactly. And in that case, the patient actually felt better, clinically improved when given formoterol, even though the spirometry only showed a tiny 1.8% reversibility.
So much less than the 12% 200 milliliter rule.
Far less. But the patient responded. It's a great reminder that sometimes the patient's subjective and objective response to a treatment trial can be more telling than sticking rigidly to numerical cutoffs from a single test.
That really underlines the art of medicine alongside the science, doesn't it?
It really does.
So beyond the clinical interpretation, the sources also give us a peek into the operational side for the practice.
Yeah, running a spirometry service takes, dedicated time, the right space.
And that clear split, often the assistant performs the test, the GP assesses the results.
Plus the equipment upkeep we mentioned, the calibration, cleaning, and careful documentation in the patient record system, and a logbook.
But there was that point in the training video transcript about who should be doing the interpretation, especially for initial diagnosis.
Ah, yes. That was an interesting counterpoint, wasn't it? It suggested that maybe diagnostic spirometry, the first-time interpretation, might be better outsourced or reviewed by someone with more expertise.
Like a lung specialist or maybe a GP with a special interest and extra training.
Right. Which does contrast a bit with the Fonderson practice's goal of the GP doing the assessment themselves.
So is that a contradiction? Or just different perspectives?
I think it might reflect different stages, perhaps. Or maybe just acknowledges the complexity. The aspiration is self-sufficiency, but maybe there's value in expert review, especially early on or in complex cases. It highlights that mastering this isn't instant. There's a learning curve.
Yeah, that seems realistic. And ultimately, across all these different source materials, the message that keeps coming through is integration.
Absolutely. The spirometry results, however good, are just one data point. You have to weave them together with the patient's story, their history, the exam findings, their symptoms, maybe those symptom scores.
To get the full picture for diagnosis and management.
Exactly. Context is king.
Okay, so looking back across this deep dive into the Fonderson practice portfolio, the cases, the training materials, what are the main takeaways?
Well, we've seen the nitty-gritty technical side of spirometry, how vital quality control and good technique are for getting results you can actually trust.
Right, that repeatability aspect.
Then there's the structured approach to reading the results using models like ROER, understanding the Z-score for better precision.
And critically, seeing how real-world cases aren't always neat and tidy. They bring challenges, nuances.
That demand clinical context, judgment, and considering the patient's whole situation. Case 8 was a perfect example of that complexity and the importance of patient preference.
So mastering spirometry in general practice, it sounds like it's this blend of technical skill, following procedures carefully, systematic thinking.
But also that crucial ability to integrate the numbers with the actual person sitting in front of you, the art bit we mentioned.
Yeah. It leaves you with something to think about, doesn't it? Consider how these objective measurements, these FEV1s and ratios, actually change the conversation you might have with a patient about their breathing, about a long-term condition like asthma or COPD. What does it really take to go beyond just getting the numbers or even just interpreting them correctly on paper to actually using that information effectively in shared decision-making? How do we ensure this powerful tool genuinely helps improve someone's day-to-day life?
That translation from data to real-world benefit. That's the ongoing challenge, isn't it? And these sources certainly give us a fascinating look at one practice's journey in tackling it.